All right. Hello, everyone. I'm Cecilia Norris. I'm currently the medical director at the Iowa City Free Medical and Dental Clinic. And I'm excited to be here to talk about one of my passions, and that is providing health care for the underserved. So I've been the medical director at the Iowa City Free Medical Clinic for the last 16 years. And over that time, we have grown and expanded with the changing healthcare environment. Today, I think it's a good idea, well, anytime, I think it's a good idea to understand your source and where an individual person is coming from when they are presenting on topics such as this. So I have long been drawn to Jesus's mission of healing and ministering to those on the margins of society. And I think the quote from Luke 9, verses 1 through 2, then Jesus called the 12 disciples together and gave them power and authority over all demons and to cure diseases. And he sent them out to proclaim the kingdom of God and to heal the sick. And the fact that heal the sick is actually in that quote. This is one of my passages that I think about. So my interest in providing healthcare for the under-resourced began in high school with a trip to the Philippines. There I saw what the lack of healthcare could impact how people worked and lived and interacted with each other. And I was motivated then to train to be able to help that. After graduating from the University of Iowa with a degree in biochemistry, I attended Washington University School of Medicine and did a family medicine residency at St. John's Hospital so that I could provide a broad variety of health care, both to adults and children. After many different jobs following my husband around while he did his training, landed at the Iowa City Free Medical Clinic, and I have just been thrilled to be in a location, a community that supports its community members, it supports its religious organizations, supports those who do not have as many opportunities and resources as most of us who are associated with the university. So I want you to think about the last time you needed medical care, because this can help put things into perspective a little bit for people who don't have health insurance or the ease of accessing health care. So what did you do? Did you just pick up a phone and make an appointment? Did you need a phone or a computer to make the appointment? Did you have to drive to get to the doctor's office or hospital? Did it cost, and how much? Or did you need to pay additional for tests, medications, and other visits? Did the medical professionals ask you if you spoke their language? So the United States spends more on healthcare than the 12 wealthiest countries, and yet has the worst healthcare outcomes. The reasons are complex. I'm not going to say that we can solve these problems by addressing two specific areas. But from my experience, I think that two of the main factors that negatively impact all of our ability to obtain health care, but especially those who don't have insurance, is our health insurance-centered model of care and the structural racism that continues to operate in healthcare. The US healthcare system is set up so that insurance is the gateway to obtaining care. Frequently, including at our local health organizations, except for the Free Medical Clinic, health insurance is required to even schedule an appointment. Frequently, the first question asked when you call to schedule an appointment is, what is your health insurance? And from the Free Medical Clinic, we have had issues with this, trying to get patients in for specialty care in particular. Because the insurance is so critical to obtaining health care, insurance companies have been able to dictate how care is provided. The whole idea is that health care is a commodity instead of a right. And because of that, the healthcare insurance companies' main reason for providing their services is to make profits to pass on to their shareholders and their CEOs. The average salary of a CEO of the top six health insurance companies in 2022 was $30 million. Despite the declining quality of care that we are receiving, the profits that are going into the health insurance stocks are skyrocketing. So we need to acknowledge that this is actually the case. And when we think about ways to improve the system, I think it's very important to ask, what is your goal? And in the United States, I feel like our goal should be to provide high quality health care for all people. Not everybody shares that goal, and I recognize that. Like I said, I think it's important to know where we all come from. But if that is your goal, then the way to do that is to maximize care and resources that go to individual patients instead of maximizing the profits that insurance companies make. So in the United States, we actually had an improvement with COVID in the number of people who were able to get insurance, because people were not allowed to be kicked off of their insurance or off of their Medicaid. And so because of that, there was a slight decrease in the number of people who are uninsured. However, and that went down from the 11% of US non-elderly adults that you see here to about 9.6%. So there are still 25.6 million people who are uninsured in spite of that. The rate of uninsurance in Iowa is 4.9%, partially because we had Medicaid expansion, which definitely impacts how people are able to obtain care. Those that live in states that expanded Medicaid with the Affordable Care Act have much lower underinsured rates than those who did not take the Medicaid expansion federal funds in order to cover more individuals. So there are, again, like the healthcare problem, the reasons that people have insurance or do not have insurance is complex. However, as you can see from this slide, the majority of people, the reason that they say that they don't have insurance is because they can't afford it. This information comes from a Kaiser Foundation study that has been tracking insurance status, racial inequality, different measures of healthcare across the United States, surveying millions of people. I've looked at these statistics over the years, and they actually have stayed fairly consistent for the last at least 4 to 5 years, that healthcare insurance is unaffordable. For example, in 2023, the annual cost just for the premiums for an individual was $8,300, and the average for a family was $24,000. Average deductible with employer plans is $1,700. So after you pay your premiums, when you have a deductible, you frequently have to pay out of pocket up to that deductible before health insurance kicks in. So the overall cost to people to be able to obtain health care, even when they have insurance, is very high. So when people do not have full-time jobs that provide benefits, when they have not been residents of the United States for 5 years, it is very difficult to afford insurance. I had an experience being without insurance twice in my life. The first time was when I was a medical resident and was pregnant with my first child. My residency ended in June, and my daughter was going to be born in September. And none of the new employers that I was trying to get a job with were willing to cover my insurance for any pregnancies of my complication or delivery. I was fortunate that I had the resources, I had the opportunity to be able to convince my residency hospital to hire me for 3 months afterwards so that I could continue my insurance. But I think that that's just an indication of how much insurance and the way insurance is connected to employers impacts the health care that we all receive. The second time was in between jobs. We do have COBRA available to be able to cover that gap. However, COBRA is very expensive. For an individual last year through the University of Iowa, I can tell you it was almost $900 a month. So this, when you aren't working because you're in between jobs, can be prohibitively expensive for many people. I'd also like to point out the second largest chunk up here, which is a 28% are ineligible for insurance. So as I said, some of that is because of an employment situation. Some of it is also based on immigration status. So people can be in this country legally working with work visas, et cetera, or going to school, but they cannot qualify for Medicaid if their income is low enough until they have been in the country for 5 years. So that is a huge gap. Refugees who we say come to our shores as part of our existence in the world community and wanting to be a good world community member, refugees can come and they can get Medicaid for 8 months. And then after 8 months, they are unable to get Medicaid until they have, again, been legal residents for 5 years. And at the free medical clinic, we have seen this, this impact greatly our young immigrant women population who is unable to obtain prenatal care. So I would just make another push out there for all of you who are concerned about maternal health, child health, and well-being. We need to do better as a state at saying we value these women. We want their health to be good so that they can deliver healthy babies. Because if you think about it, and even if you don't want to do it from an ethical or moral standpoint, financially this makes more sense. Because once the babies are born, they will be on Medicaid. And if they have preventable congenital defects because of lack of access to prenatal care, the state and the taxpayers are going to be paying for those individuals as well. I'll talk about it a little bit later when I talk about the prenatal clinic, but just something to keep in mind about how these impacts of denying health care really come back to hurt all of us in the long run. The second topic that I mentioned that I have become much more aware of in my work at the free medical clinic over the last, especially 10 years, is the impact that race has on not only accessing medical care, but obtaining quality medical care. The CDC last year actually identified racism as a public health threat. There are disparate health outcomes among especially Black compared to white individuals and Indigenous people compared to white individuals. Health expectancy is 4 years less pretty much across the different male-female groups. There is an inequitable access to health care. In fact, the Black individuals are 52%, or excuse me, Black individuals with mental health illnesses, only 38% of them have been able to obtain care, whereas 52% of white women have been able to obtain care. Black individuals and Hispanic individuals are between 1.5 and 2.5 times more likely to be uninsured. And then this is the last three are things that I hadn't really thought about until actually, honestly, 2020, when I started looking into more the racial inequities across our society and thinking about how that impacts me and my own profession. There have been numerous studies about, even among healthcare professionals, the implicit bias tests show that when they are presented with a Black face, they are more likely to associate it with negative words than if they are presented with a white face. I realized that in my training, I had a lot of biases that were presented to me. I was taught that Black people had a higher pain tolerance than white people. And when I look back at the news articles now that are bringing this out, and realizing just how naive I was to just accept that as a white trainee and say, okay, so we don't have to worry about the women in labor who we're saying don't need an epidural because they are Black. Um, that in retrospect, that is a horrifying mistake that I made in my training. There are more and more studies coming out about even correcting for having insurance, income, and education levels. Black individuals are less likely to receive the most updated care. They are more likely to, for example, with diabetes, more likely to undergo limb amputations instead of having limb amputation or limb preservation procedures performed. And when we do more research, I suspect we are just going to find more and more of these issues going on. That brings me to the research aspect, which is that for decades or centuries even, Black people have had research performed on them to benefit others instead of being subjects for research to understand how better to treat their individual problems. I think many of us have heard of the Tuskegee experiment, where Black servicemen were allowed to have syphilis progress to its end stages just so they could see what those end stages were instead of giving treatment. Or Henrietta Lacks, who was who died from cervical cancer, and without her family's permission, her cells were harvested and have been used to promote research in many ways in probably hundreds of different fields across the country. There are reports coming up. We know about forced sterilization of especially Indigenous women and Hispanic women, procedures that were performed without proper consent. And this impacts healthcare in so many ways, because when people have been treated like that for generations, that generational trauma causes mistrust in our healthcare system, justifiably so. And so we need to find ways to be able to reestablish that trust in order to be able to provide the health care that these individuals deserve. And then last of all, something on this slide is the lack of representation of people of color in the healthcare profession. And there was recently, or I guess it was in 2019, a JAMA article that surveyed hundreds of thousands of healthcare professionals about race, and the 10 advanced degree health professionals, 56% were white and only 5% were Black. So this just shows that's a huge discrepancy between the population demographics. And those are the people who are making the decisions about what is important. And so I think that there are several organizations and training programs across the country who are recognizing this problem and are trying to make efforts to improve the representation of people with the different skin tones in the healthcare professions. So with all that bad news, now I'm going to turn over and talk about some of the things that we are able to do here in our community to help this problem. At the Free Medical and Dental Clinic, our mission is to provide quality, comprehensive healthcare services for the uninsured and underinsured in Johnson County and the surrounding areas. The clinic was established on the idea that access to healthcare is a basic human necessity and a right. So the clinic provides needed care to anybody who does not have insurance, and to some people who are underinsured, although that is becoming a little bit more difficult to be able to determine what that entails. Without these services, many people would either forego healthcare or wait till the problem was so bad that they needed to go to an emergency room, or go to emergency rooms for minor problems. So it really does benefit the whole community to have the free medical clinic here to be able to provide some of these services. The clinic started in 1971 at the top of a building downtown by a group of medical students and some faculty to provide really basic healthcare services like testing for urinary tract infections and treating colds. And in the 80s, it switched over to being a big site for HIV testing for individuals. Today, we are located in a actual medical building at 2440 Towncrest Drive on the east side of Iowa City. We offer not only primary care, but chronic care management, several specialty clinics. We work in partnership with many community organizations in order to help our patients obtain services, not only the actual doctor's visit. So the social determinants of health are something that are kind of buzzwords in the medical care industry right now. It was a term coined, I believe, in 1999 that talked about different impacts of things such as food insecurity, transportation, neighborhood violence, that all of these things could impact the health of individuals. We've really known that at the Free Medical Clinic probably since its inception, but now we have some actual words to put to it. We have ways to think about it in different, to be able to say this is something that we want to work toward improving. And so we look at these basic, we look at these 6 categories to see where we can help individual patients. So just briefly, I'm going to go a little bit more into detail, probably under some specific things about the free clinic, but economic stability, obviously, if you're healthier, you're better able to work. Not having access to healthcare or steady employment, it's a circle and it keeps going on and on. Neighborhood and physical characteristics, in our case, it's just something that we're mostly aware of where our patients may be coming from. We actually get patients from across the state. My one patient who I had who drove all the way from Davenport no longer needs to do that, but that just gives you an idea about the reach of people that we can serve. Education is something that we have been very strong about trying to educate our patients while they're in our clinic, because it's very difficult to get a hold of them frequently. Afterwards, we try to work with patients where they are. Many of our patients actually have not even completed grade school because they're coming from other countries. They do not read or write in English. So these are some things that we keep in mind when we're providing care. We're very fortunate to have partnerships with HACAP and Table to Table to provide food for our patients. At visits, it can be hit or miss. It depends on what their supplies are, but at least there is food present in the clinic for those who are food insecure. So the challenges specifically to the Free Medical Clinic are the language and cultural differences. I have been checking our schedules have what language or some category of language that individuals speak. And I can tell you that for the last 3 months, at least 90% of our patients do not have English written down as their first language. Some of them do speak English, not in varying fluency, but that puts a huge burden on both the patients to understand and the providers to be able to explain and provide the best care available. The economic resources of our patients impact their abilities to get labs, medicines, radiology tests, that type of thing. And so those are some of the things we're able to help with. As I mentioned, the food insecurity. I'm also seeing a lot of people with more complex health conditions. They frequently did not receive health care for a long period of time before coming to the Free Medical Clinic. And so their diabetes is not controlled. Their high blood pressure is not controlled. Patients are coming in with diabetes, high blood pressure, chronic kidney disease, cancer, and an immunologic problem. And so it's not the bladder infections and the upper respiratory infections that the clinic kind of started treating. And so we've had to evolve over time to figure out how to provide the care for those patients. The bottom two are things that we're still working on. We would really like to be able to provide mental health services, but like in the rest of the country, it is very hard to get those providers, especially those providers who speak a different language or represent a different skin tone. And then dental, vision, and hearing health are very important to overall health, but they frequently aren't recognized by insurance companies as being important. And so those services are not covered, and we are working on ways to better improve those. So these are a bunch of different statistics that you can kind of peruse at your leisure of the patients that we see. Like I said, the vast majority are uninsured. Those that are underinsured, or excuse me, those that are not included in that 98% are probably the ones we do STI testing for Johnson County, and we don't ask about insurance status for that. As I said, most are from Johnson County, most are employed, and well over 90% are less than 200% of the federal poverty level. Many patients have not seen a physician for a long time, and as I mentioned previously, we have the language and the medical complexity to deal with as well. So taking care of a patient at the free medical clinic actually starts well before a patient is actually seen by a provider. We have an amazing staff who takes our phone calls, takes walk-ins, staff who schedules volunteers to be able to help patients. And then after the visit, our care manager, who's pictured in that last slide there, will meet with patients to try to explain some of the programs that they may need to be signing up for, or how the care management program works. At the clinic today, we offer 6 to 7 medical clinics weekly for acute and chronic illnesses, in addition to 2 to 3 specialty clinics a week. Actually, I think that's probably going up to 4, because we are doing more some daytime specialty clinics. The dental clinics, and we do have a laboratory and medication dispensary on site. We're able to do some basic medical tests, such as an electrocardiogram to check the heart, or spirometry to check lung function. If necessary, patients are able to obtain some services, some X-ray services, through different organizations. Our medical clinics include our acute visits, which are typically the sexually transmitted infection, bladder infection, back pain, injuries. We have a chronic management program, which takes up the majority of our daytime chronic patients for diabetes, hypertension, immunologic problems, kidney and liver issues, asthma. And then a couple of programs that we have just become more involved in as we've seen the need increase are women's health and latent tuberculosis evaluation and prescribing, which is not a separate clinic in and of itself, but is done during the acute and chronic clinics. The specialty clinics we currently offer are prenatal, dermatology, ophtho, gynecology and contraception, ortho, rheumatology, physical therapy, and we have some wonderful renal docs, including our own Maria Story, basically on call to come in and see patients when they need that. Our laboratory is another place that we've tried to increase the services to better provide care for the patients. And so a lot of these tests we are able to do in the office and give very rapid responses for the results. And one of the big places that has had an impact is our hemoglobin A1C machine. When patients have diabetes, we can now, within 5 to 10 minutes, get a simple fingerstick blood test that tells us their average control over the last 6 weeks. So when they're in meeting with the provider knows whether a medication needs to be adjusted, whether they need to be started on insulin, whether we need to work more with their diet or exercise, and can present that instead of having to make a phone call, maybe having to deal with an interpretation issue or translation issue over the phone. So this has definitely improved our diabetes care for our patients. As I mentioned, we do get some free plain x-rays and ultrasound tests, both from Mercy and Steinler, and we have figured out how to get discounted radiology services from Corridor Radiology and Muscatine Radiology. Muscatine Radiology is about 1/10 of what the cost at the university is for MRIs, just as an example. As I said before, a lot of patients have difficult time purchasing medications, even those that are on the $4 plan at some of the pharmacies. So we purchase a lot of medications outright. We're able to do that at cost for some medications through the university. There are also some national discount pharmaceutical programs that we can purchase from. We try to get our patients signed up for patient assistance programs, especially for the insulin. When insulin was so prohibitively expensive, the pharmaceutical companies did have programs that would get insulin for patients. However, their eligibility requirements could be pretty strict, and so we've had to learn how to provide care with some of the older types of insulin, the types I trained with 30 years ago, instead of the more effective, less side effect causing newer insulins. But we work with what we have and try to provide the best care with the resources that we have available. One of our big programs that I think helps to keep people from developing complications is diabetes education. And we're very fortunate right now to have a bilingual individual who is able to counsel patients in diet, exercise, monitoring. She is amazingly available for follow-up over the phone and able to see patients for sit-down visits face-to-face. So we're really happy that Anyat is at our clinic and able to provide this service. The other big program is our case management program. This is something we've probably had for about 15 years that just gets a little more, we add a little bit more to it all the time. Currently, our case manager, Stacy Wilkerson, does an awesome job knowing the different patients who have difficult to control high blood pressure, diabetes, hypertension, other problems. She will go out of her way to try to find extra help for these patients. We've had patients who have severe sleep apnea, so much so that one of them would come to her visits and fall asleep while talking to the doctor during the appointments. And through Stacy's help, we were able to get that patient a CPAP machine, and the improvement that we saw within a couple of weeks was just phenomenal. And so, again, this is a program that we've really seen impacts in people's abilities to be able to work and lead a healthy life. So two other clinics that I would like to briefly touch on are related to women's health, and they actually both came about in response to, I'm just going to say it, the attack of the Iowa legislature and governor on women's health care services. In 2017, the state decided it was going to cut funding for Planned Parenthood for all services, not just abortions, without having any sort of safety net in place to provide those care. They said they had a safety net, but take it from somebody who is on the receiving end, there was no safety net in place. So actually, I'm sorry, that is about the women's health clinic. The prenatal health clinic, in 2018, the state privatized Medicaid. They then changed how they paid providers to provide pregnancy services. And so they separated the prenatal care from the delivery. And so in the past, doctors would be reimbursed at the delivery for like the whole, your investment over the previous 8 months while you were providing prenatal care. And so even though they were losing money because Medicaid didn't reimburse enough, they weren't losing as much money. So they could continue to do this for some patients. Well, after the privatization of Medicaid, doctors were reimbursed separately. So there was one chunk for the prenatal care and another one for the delivery. And so patients who only qualified for emergency Medicaid at the delivery, the delivery was paid for. So there were many providers who ceased to provide prenatal care. If patients did not qualify for Medicaid, they were pretty much out of luck. So fortunately, some providers in family medicine at the university saw the disaster of this happening and approached us about offering a prenatal clinic for those without insurance. And it is our fastest growing clinic, I think, because the great need of, as I mentioned, those refugee women who can have Medicaid for 8 months and then they lose it for 5 years. And most of these women are here legally, but just don't qualify for Medicaid. From our perspective at the Free Clinic, we never ask about status because each individual is a individual person, and we are treating the person to the best of our ability. So the clinic now, we have it every Thursday night and 2 Monday mornings out of the month. I believe they're seeing 12 to 14 patients at those clinics, so they're busy clinics. But they recently published a paper about how they've had better outcomes for the patients that they're providing these services for, and they have the control group of those who didn't get care and are showing up with no prenatal care to deliver at the university. So both cost saving and health saving. And they've also now started to be able to provide long-acting reversible contraception after delivery to allow women to better plan their family size. Then the other one that I started talking about earlier was the cutting of funding for Planned Parenthood, and the effects of that were basically that our clinic saw for the first 2 years between a 30 and a 60% increase in requests for appointments for women's health issues such as contraception, pap smears, breast exams, menstrual irregularities. Just it was overwhelming, to be honest. And so we tried to figure out how we could fill the gaps that we were finding. And eventually we've been able to start offering what we call Wednesdays for women, or miércoles para mujeres, which provide group classes in Spanish or in English to discuss different contraception options, risks and benefits of each, so that patients can think about what might be best for them. And then they can have an individual appointment with a provider to determine what they want to use. We've been able, through a lot of nice private donations, to be able to obtain some of the more expensive long-acting reversible contraception, such as IUDs and Nexplanon implants. And so patients can get those either at the appointment or shortly thereafter. We have also seen a huge demand in the need for pap smears, and then we would eventually like to be able to offer the follow-up testing when pap smears are abnormal, because as I mentioned before, with patients not being able to obtain health care in their own countries, not having access to the HPV virus or pap smear screening, we see a much higher percentage of patients who need colposcopy because they have precancerous changes. In fact, it was when we did a 6-month overview, it was 60% of our patients. I suspect it's closer to 40 to 50, but that's still a lot of patients who need these services. As I said before, at the Free Medical Clinic, we are very fortunate. We have a lot of organizations in this community who want to improve healthcare for our community overall. So these are just a few of the organizations that we partner with. We do get support from several of the medical facilities. I am waiting to hear what's going to happen with the Mercy UI merger, but hopefully, since they both currently support us by providing lab tests and x-rays, they will continue to be able to do that. Johnson County and the United Way, as well as the cities of Coralville and Iowa City, provide our other large organization funding, and then individual donors make up the rest. We still have a lot of challenges. We're growing, and our building is older. So we're crowded. These are our hallways that we are using as storage units. Really, exam room space is the biggest limitation currently to us being able to see more patients. We have providers who want to work and to see the patients. We just don't have the physical space to be able to do that. We did just receive a $1 million grant from the city to be able to expand our basement, and we're keeping our fingers crossed. The construction is going to be starting soon. So hopefully that will alleviate that issue. And so I hope that I explained a little bit on how we handle some of the challenges specific to our community and the free medical clinic. If I didn't, I'm always happy to talk about the free medical clinic. So if you have further questions, feel free to contact me. I see a question out there, Jeff.
If people are not medically trained and they want to do more than just give money, do you have volunteer opportunities?
We do have volunteer opportunities, and honestly, I think as our expansion moves forward, we may have we will have more of those opportunities. We are also wanting to transition from paper charts to an electronic health record, and so that we will be looking for volunteers to help us in that field. Anybody who volunteers does need to sign a confidentiality contract or agreement that states that anything they see in the clinic they won't talk about outside of the clinic that pertains to specific patients. But if you want to volunteer, you can go on our website. There's an application that applies not only for healthcare professionals, but if you would want to do reception, file, clinic assistant, and as I said, we'll probably have more opportunities coming up. So we have a clinic, one of our full-time employees is a volunteer manager. So she takes care of that, Stanzi.
And then with the purchase of Mercy by the university, are there any special needs for the free medical clinic right now?
There will be. Again, everything moves kind of slowly, even though we knew this was coming since last August. And I have a meeting at the beginning of February to try to figure out where the free medical clinic stands and how much support we're going to be able to continue to get from the university. I would really like to see us be able to expand because I feel like the free medical clinic is in a unique situation. We get requests all the time from discharge planners at the hospital to see the patients who don't have insurance. We get requests from medical students who want to work with people from different cultures. We get requests from residents who want to be able to use their skills a little bit more than they during training than they can at the university. And really, I think with our expansion and the patient population that we have, we're in a great position to be able to provide those teaching opportunities as well as the patient care opportunities. However, we are a small staff overall, and so we would need support, both personnel and financial, to be able to do that. Once I find out where that's all going to pan out, I will probably be in contact. Let Jeff in the office know what sorts of needs we have at the free clinic, and I'll be sure to advertise when we have other things. So I did just want to end with this quote, since Martin Luther King Jr. Day is tomorrow. He stated, "Of all the forms of inequality, injustice in health is the most shocking and inhumane." So with that in mind, go forth for Martin Luther King Day, and I hope you can do a day of service. Feel free to contact me either through the free medical clinic or through the church. Thanks for your attention.